All right, welcome everyone to today's CAiRE webinar on AI and public health. So I'm really glad to see my friends and also colleagues and the world's experts on AI and public health. So let me introduce our panelists today. So we have Dr. Oliver Morgan from the WHO. He's the director of the Health Emergency Information and Risk Assessment Department in the World Health Organization Health Emergencies Program. And also from 2007 to 2016, Dr. Morgan worked for the US Centers for Disease Control and Prevention, CDC. So he led critical leadership positions in the Ebola response. And he was also the CDC country director in the Dominican Republic. And among other achievements, he also publishes extensively. He's got a PhD in the epidemiologist, and he's a world's expert, obviously, in the forefront in the current fight against COVID-19. And then we also have I'm gonna spotlight video. Then we have Ambassador Amandeep Singh. Ambassador Amandeep was, actually trained as an electrical engineer, and he got a PhD in nuclear learning in multilateral forums, and he's currently directing the international AI robotics initiative, for the in the United Nations. And he was actually, we met as when he was heading the permanent representative to the Conference of Disarmament in Geneva, and he was head of the Disarmament and International Security Affairs Division, and so on. So he actually, I would like him to talk about himself and his current effort on the digital cooperation for AI and for public health. And then we have so Dr. Shahnaz Miri. So she's actually a medical doctor, neurologist, and in the Georgetown Hospital, Georgetown University Hospital. And you have a very, very interesting story and experience in your experience with diagnosing COVID-19 patients and how you came about coming up with AI programs in the process. So welcome. And then we have the Professor Tim Chan. UST people know him. He's our Dean of Engineering. He's also an expert in computer vision, and he's done a lot of work in using AI for radiology. And he will introduce some of the AI for COVID-19 projects at HKUST, including our own project and our collaboration with EIOS. All right, so let me go to Dr. Morgan first. So Oliver, I remember we met was it last summer? In Dalian at the World Economic Forum. And you talked to me about using AI, especially natural language processing, which is my area, in helping with epidemic prevention and detection. And I must admit that at the time I thought, I'm not sure how we can help. Like, how does AI have to do with, natural language processing have anything to do with epidemics and pandemics? I have to say, at the time I had no idea. But that seemed like a lifetime ago. And today we're actually finally collaborating using our natural language processing technology to, in your initiative, EIOS initiative at the WHO for epidemic detection and prevention. Can you tell us more about what you are doing at the WHO and what is your EIOS initiative?
Great. Well, thanks, Pascale. Let me say it's a real pleasure to be here with you. And thank you so much for organizing and inviting me. It does seem like a lifetime ago since we met last summer in Dalian. And clearly a lot has changed it really underscores the importance of the work that we do collectively. And I think that if there are a couple of points I'd like to get across to our colleagues who have joined us for this webinar, I think one is, collective global action is absolutely necessary for pandemic control, especially, as we go forwards when looking at applications of technology to solve a number of problems. Doing this collectively is going to be extremely important. The other message is that we should be always looking at information technology, data science as adjuncts to existing approaches for disease control. So it's really important not to see digital solutions as replacements for existing either clinical care or existing public health measures, but they're really ways that we can extend our capabilities. So if I can describe a little bit what we do at WHO, then that'll help to illustrate my 2 points. Here, I work in the Health Emergencies program at WHO, and we are responsible for a number of different functions, but essentially our core function here at WHO, and the core function of my department, is to identify new health threats of any nature. They could be biological, they could be chemical, radionuclear, they could be weather events, or they might even be political context that could lead to crisis. And our job as a department within the emergencies program is to identify these events as quickly as possible, and to alert not just our leadership internally, but also to work with countries and other organizations around the world to understand in more detail what is happening. We have a number of fairly well-defined steps along that pathway, which includes detecting signals, and this is what I'll come back to in a minute, because this is where you and I are collaborating, and this is where we're really leveraging natural language processing and other AI technologies to help us. So we detect a signal of a potential event, and then we have to do some verification to understand whether this is a true signal or a false signal. And then if we believe it's a true signal, or a signal of a true event, I should say, we then have to investigate. And this is where our, let's say, traditional public health measures start interacting with our technological approaches, because the investigation of events around the world really requires people to be on the ground and go and see and investigate what is happening. Following that verification and investigation on the ground, we may or may not mount a response, or we may decide to continue to watch the event to see if it develops or whether it does not develop, and then that process feeds into a decision-making step, whereby at WHO we formally kind of register or log all of these events that we're watching or participating in, and then we manage those events proactively going forwards until their resolution. So there's quite a long chain of events that happen. And to give you an idea, I mean, I would say most people who are not involved in public health, or even who work in maybe some parts of public health, only get to see or hear about some of that work when there is a big event. So for example, for the last almost 2 years, we've been fighting an Ebola outbreak in the Democratic Republic of the Congo, which has been fairly well publicized. And of course, we're all experiencing the pandemic at the moment, and there have been several other high-profile events. But actually, there are thousands and thousands of events happening around the world every week and every month. Many of those do not rise to the level of making a news story, or really arriving at wide public attention. But we probably recent estimate, we're looking at about, we look into detail about 3,000 signals every month globally. And we do some type of verification on those 3,000 signals every single month. And then we do investigations, more detailed investigations with either our WHO country offices and the ministries of health in the countries or other partners, depending on the event, for about 300 events every single month. So there's a lot happening out there. And so our job is to really detect which are the priority events that WHO must step in and support, and where we must, let's say, assess what the risk is and take some type of action. Now, if I come back to the collaboration that we have just started, and to talk about how we apply some of the some data science technology to this effort, we've over the last 3 or 4 years, we've moved very assertively into leveraging technology to harness the huge amount of information that there is currently available online in various formats through various channels, and related to public health or connected to public health in some way. Traditionally, how we would detect outbreaks of disease would be a country or a local area within a country would, through its healthcare facilities, through its family doctors or general practices or hospitals, would count the number of patients coming into there. It would add up the number of cases each week and report that, let's say, to either the district level or maybe the capital directly. And then there would be a team of epidemiologists in the Ministry of Health who would compile those data into an epidemiological bulletin, usually a hard copy document, and then pass that to a senior official within the Ministry of Health. Now, that's the traditional approach which still continues today. This is the main way that many countries, or most countries, really do public health surveillance for many different diseases. And now it's more, let's say, more digitized. There's been a huge investment over the last 20 years around the world to digitize that surveillance process. But in the end, it's still a fairly traditional process of reporting them in aggregate form to the central level in a country. And then we would ask that countries share reports of outbreaks or other public health events with the WHO, so that we would then build a composite picture of what's happening around the world. Now, as you can imagine, that process is can take some time, and it's very resource intensive. And what we've been working on is to create the next generation of global surveillance tools that really benefit in the new global data architecture that we live in. The Epidemic Intelligence from Open Sources initiative, which is the initiative you and I are collaborating on, really has its roots going back almost 30 years to work that WHO did with the Public Health Agency of Canada to start looking at whether digital information available online could indicate or provide some early indications of whether outbreaks are happening. And fast forward to today, the amount of information out there that's available online is just enormous. And we look for all sorts of different types of information, whether it's from professional groups that have online information exchange, or tapping into ministries of health websites or other websites where information is published about what is happening, or through to different media articles about events that might be happening locally. And we take all of those pieces of information and distill that into what I mentioned, which was signals of potential public health events. Now, we process hundreds of thousands of pieces of information every week to find public health signals, and then we use natural language processing to help us manage all of that data. So the way that we use artificial intelligence is to make our human process much more efficient. In the end, the decision about whether something constitutes as interesting or important signal that we must investigate further is a human decision that that one of our analysts takes. And the important point here is that our analysts have huge amounts of experience in a number of different settings. We have, as you would imagine, an international team here at WHO, and understanding context is really the most important thing. And while we're working together, and that's part of the project we're working with you, is to help understand the context of these signals a little bit better. It still requires a kind of human brain computing power and experience to truly understand how a number of different features fit together and whether that constitutes maybe a signal of public health interest. But using AI allows us to review huge quantities of data, manage that in a efficient way, and then leads to us detecting various public health signals that we can investigate further and further. The EIOS project, and I think you'll share a link to the website for that initiative with the participants on the call. This initiative is now, we're extending this initiative further and further, so to provide this platform for other countries also, because the larger the number of users and the larger the number of different sources of information that are fed into the system, obviously provides a richer opportunity for us to collectively understand what's happening. And we have many instances where we have communities of users inside the EIOS platform who share information about different events. And this becomes particularly important where we're working across disciplines. So we work a lot with people who work in the animal health sector. And so it's really critical for us in the human public health side to understand what's happening in the animal health side, to detect where there may be outbreaks of diseases in animals that can affect humans. So, the collaboration is expanding. We currently have around 30 different institutions and countries who have been using the EIOS platform, and we have about another 30 that we're fast tracking onto the platform in the current COVID situation. I can see that you're pulling up the website of the EIOS for the EIOS initiative, and maybe we could just, I can conclude, Pascale, if you could show the video that's there, which gives a quick summary of the EIOS platform and what it does. So back to you. Yes, please. Thanks very much, Pascale.
Thank you.
Say that since late October, there have been 583 confirmed cases of microcephaly.
Scientists are analysing samples from across the country in a race against time.
West Africa Ebola outbreak has put 22 million people at risk.
Every year, there are significant threats to our safety, our health, our livelihoods. Dense urban populations and an increase in global travel and trade allow these threats and diseases to spread further and faster than ever before. And while best efforts are being made to respond quickly, it's often after an outbreak is well underway. But what if there was a way to minimize the impact on human lives and economies, and to avert future crises? What if there was a unified, One Health, all hazards approach which would allow us to detect, assess, and respond to these threats sooner? EIOS, the Epidemic Intelligence from Open Sources initiative, brings together new and existing systems into a single collaborative web-based platform which screens through hundreds of thousands of open source reports and articles every day. It helps identify unexpected or unusual information, allowing cross-disciplinary experts to filter and focus on crucial content. Information can be shared across the network, allowing them to respond rapidly and effectively. Led by WHO, the EIOS initiative pushes innovation and technology to the forefront of future global health detection, preparedness, and response activities, while establishing best practices and standards for epidemic intelligence frameworks. By harnessing evolving technologies, the EIOS initiative also brings new opportunities for public health, such as applications for natural language processing and artificial intelligence, interactive detection and analysis, and real-time monitoring of stories as they unfold. Through collective efforts and with endless possibilities, this initiative stands apart as a unique, cutting-edge resource for saving lives around the world.
Oh, great. Thank you, Oliver. I will come back to you with further questions. So now let's move to Ambassador Amandeep Singh Gill. I will spotlight you. So, so Amandeep, we met when when you were heading the UN expert panel, right, on the lethal autonomous weapon systems. And so it was a big discussion at the UN with all the member states. And it was very high on the agenda was the question of the ethics of AI. Obviously, in this case, it was the lethal autonomous weapons. And you are now also a specialist, in terms of AI ethics and governance. And since you have you are now heading the so it's I-DAIR, the International Digital Health and AI Research Collaborative at the Global Health Center of the Graduate Institute for International and Development Studies in Geneva. So, so you're clearly interested in using AI and for public health, and in the current pandemic, it's more relevant than ever. Can you tell us about your initiatives and your views on the AI governance in this case?
Thank you very much, Pascale, for that introduction. Thank you to you and to Dean Chan for this opportunity to speak to the university group today. This initiative is a follow-up to an exercise that the UN Secretary General asked me to help him with. This was the UNSG's high-level panel on digital cooperation, which Jack Ma and Melinda Gates chaired. So I was executive director for this effort. And we came up with a report last summer in which we discussed how to get to the next stage of using digital technologies to drive development, inclusive development in particular. And our sense was that we would need new data commons, new digital commons, new sets of digital public goods, which combine common rails to accelerate innovation, to scale responsible technologies, as well as guardrails, this ethical side, the governance side that you mentioned. And you would recall that when we were discussing lethal autonomous weapon systems, ethics was one part of it, but then there is existing law. So if law is the floor, ethics is the ceiling, and where do we locate our efforts in that context? I continue to be still involved with that discussion, for example, as part of UNESCO's new expert group on AI ethics, where we are drafting a recommendation for the international community on that issue. But most of my focus now is on this practical initiative to see how digital technologies and artificial intelligence can help with the achievement of SDG 3, the Sustainable Development Goal related to health and well-being for all. And the timing is perfect in the sense that WHO has come out with a new digital health strategy. A number of countries are interested in using digital technologies to reimagine health, and this current crisis, the COVID-19 crisis, has shaken us all up and forced us to rethink our approaches to public health. So we all know that there is the opportunity. And as we've seen in other sectors like financial inclusion, digital offers a transversal way to reinvent delivery of services. And we have the tools now to be able to use AI. But there are significant challenges. And my main point today is that AI is not ready for showtime yet. So there's a lot of effort required to get AI ready for resolving these global problems of health for all. For one, there is missing data. We don't have enough information that allows us to take decent, good quality decisions. The human body is incredibly complex, much more complex than other physical systems that we've modeled before. And health systems themselves are incredibly complex. Social issues, economic issues, political issues come together in very unpredictable ways. And then whatever we have today, it is in fragmented, poor quality data sets, which are not interoperable. And we have this problem of a zero-sum view of data, particularly when it comes to combining private and public data sets. I call this problem the misuse problem. And finally, we have the governance issue. There are concerns on security, on privacy, informed consent, and this is the misuse of data problem. And this is the context for I-DAIR. We seek in the long term to define, develop, and share public goods, following on from where Jack Ma and Melinda Gates left us last summer, pooling strengths across various sectors, engaging young talent, and giving them the passion for solving global problems, in a sense like a CERN for AI in health. And obviously, if you don't have the digital health infrastructure to take advantage of these opportunities, you're not going to get far. So part of our ambition is to develop impact fund, which would invest in such infrastructures and which would also invest in these global research challenges. Overall, in terms of data and AI, we seek to go to the next levels of interoperability and develop new benchmarks and governance principles in collaboration with significant actors such as the WHO. And all of this is envisaged not as a centralized bureaucracy, but more as a hubs and spokes architecture. Now, this brings me to my second point today. So what are the areas in which data and AI can really make a difference? And there are a number of areas that we've shortlisted. I project some 10 areas for you and the audience today. This includes the knowledge mapping issue that Oliver referred to, the kind of live, passive and active tracking of what's happening out there. It also leads to this point about real-time epidemiology, the modeling of it, real-time data integration, presenting those results in ways that are more intuitive for policymakers. And obviously at the heart of it is issues around interoperability, data architectures, benchmarks, and so on. I want to conclude with a quick look at what's happening today in the context of the COVID-19 response. How are digital technologies faring? Now, I would say there has been an attempt to use this opportunity to fast-track digital responses. In this typology, I think you'll see at number 3 exactly what CAiRE, your project, is doing. There is also interesting work around remote triage and testing. I'm sure Shahnaz will speak to that today. Particularly interesting for me in the context of some pilot projects we're doing in India is how do you bring testing results across different testing typologies together? And how do you bring triage and risk mapping into this scheme for managing the healthcare cascade? And then the modeling aspect that I alluded to earlier. So far, the models that we have seen are very limited. They come from a few geographies, and this virus is very local. It interacts with host communities in ways that we don't understand fully. So there's need for modeling diversity and dashboards diversity. And this links with the very fundamental rationale of I-DAIR, which is to build capacity in an inclusive way to take the data science opportunity, take the AI opportunity fully into the count when it comes to moving the needle on the sustainable development goals. So I'll stop here and look forward to a lively interaction with those on the chat. Thank you.
Well, thank you, Amandeep. Shahnaz, if you don't mind, I'm gonna go to Dean Chan first, because Shahnaz, your story is very personal, and I want to leave that maybe towards after everybody introduces their projects and our projects. Is that okay?
Yeah, of course.
Okay, so let's go to Tim. Tim, maybe you can tell us, what's been going on at HKUST in terms of AI in our effort to help with fight in the fight against COVID-19.
Yes, thanks, Pascale, and thanks all the attendees today. I have the honor to quickly share with you about HKUST all-around efforts to help fighting COVID-19 pandemic. Can you see my slide here?
Yes.
All right.
It's in slide mode, not in presentation mode. It's okay?
Oh, that's right.
All right.
Now it's you probably see the main screen, right, instead of the presenter's view. It's not, okay. So very quickly, I think HKUST, we're very proud that many of our faculty with years of research effort having some results really matching well to the need of our society in such a crisis. Our PAO, our public office, has been publishing a pamphlet. Just give a quick overview of our overall efforts on fighting COVID-19 pandemic. The pamphlet is available on university website. So you can quickly go into the homepage of our HKUST university website. You will be able to find a small pamphlet, which at a very high level give you a quick summary of wide range of activity from prevention to mitigation to treatment. I don't have time to go over everything in detail, and being the Dean of Engineering, I'd like to highlight some of those which have strong engineering elements, especially the AI aspect of using machine learning, data analytics, and in artificial intelligence to fight this virus. So the first one is our chemical and biological engineering faculty member, Kin Long Yun. For years, he has been developing some solution, which is antimicrobial coating, which can kill viruses, all kinds of germs.
I think I have one here in my office.
Yes, actually, thanks to our president and our donors. Actually, every employee on campus get the solution. And this is a very fascinating story. This solution has been there for quite some time. And the most unique part is it can be effective on service for over 90 days. So for a situation that you will not be able to constantly spreading and constantly cleaning the place, this has a very special lasting effects. So what's interesting is making the solution is easy, but it was not a production for a while. So the bottleneck, when there was a sudden demand for this, what they are lacking are bottles. How to put the solutions in the bottle so that they will be able to ship. So thanks to our university staff, they actually making those bottles, printing the labels, etc. And quickly, within few weeks, this reached out to the global platform for example, this is one of a 200-300 news article. This is an article in the US from the Hill, and you can read the headline. And UK, globally, everywhere, and making news about this. And 3-4 weeks ago, there was still a kitchen operation in a very, very small production environment. So the fast pace from research all the way to global platform to fighting this is a very fascinating story. Another one is our IEDA Professor Richard So. He helped the government to quickly set up the smart fever screening systems on the border. We may already seen at airport that there are low throughput fever screening system. But once you have a border like between Shenzhen and Hong Kong, for example, that you have tens or even hundreds of people crossing, you have to have a high accuracy, high throughput. And more importantly is indoor environment with temperature variation, etc. That's where the AI and the deep learning technology comes in. And he quickly, within few days, set up 7 systems placed in 7 border control line, and helped really a lot in early days. I mean, the late January, early February time for border control. Another one is our EC and the computer science faculty member, Ming Liu. He has been working on autonomous vehicle for quite some time. Actually, the big picture he's standing in front still look like very young, like a graduate student. But he has been working on this as we're expert in self-driving car, autonomous car. His target is low speed, 20-30 miles an hour for delivery, and has been used in industrial parks such as Foxconn, a few places. But once the pandemic outbreak occurred, clearly there's tremendous worry and shortage of human contact, that shortage of delivery service people to deliver goods, grocery to the highly infected region. So here comes the rescue of this vehicle that doing delivery. On one hand, this you can upload in a safe area and then deliver to the highly infected region. And again, getting into the global platform, just a few weeks ago, IEEE Spectrum, the robotics news platform, the headline is his article. And another one is our EC and the chemical biological engineering professor, Matthew McKay. He has done a lot of work using AI technology to do protein vaccine development. And in pretty early stage of this COVID-19 outbreak, he quickly identified some genetic sequences, a similarity between the SARS virus, which in 2003, and the latest COVID-19 virus. So this similarity, particularly they identify a set of so-called B cell and the T cell epitopes, which derive from the SARS, which are the protein fragments that can trigger the immune responses against SARS, has similarity for triggering the immune responses against the COVID-19. So this is a very important finding for further vaccine development. Another one from computer science engineering department, Gary Chen's geofencing technology. He has a startup company doing the indoor localization geofencing. And when the quarantine comes, especially self-quarantine, it's very difficult to monitor whether the confinees is really confined to the place they're supposed to be. Yeah. So with pairing with the electronic Bluetooth wristband, together with this app, which can do very accurate indoor localization, provide a perfect solution to really check whether the home confinees is in complying with the quarantine order, and automatic alerts the relevant authorities if the person going somewhere outside. And finally, is everybody familiar with this very interesting and award-winning system that CAiRE Center, under the leadership of Pascale, has developed a summarization system that questioning and summarizing system, and winning one of the 10 key questions in the COVID-19 research data challenges competition. I think Pascale, I assume later you will give a little bit more detail to share with us. That's how the fascinating technology behind. There are tens of thousands of articles. Some are right ones, some are the fake news, and some are conflicting. Even for those legitimate ones, I think there's a lot of overlap, conflicting information, etc. So a very powerful summarization and QA system is really timely to provide the general public the tool to understand the virus and the coping with the necessary actions. So very quickly, the second part, my assignment is to talk a little bit about AI for medical imaging analysis. So I know my time is limited, so let me just quickly share with you my view on this subject, which I feel on AI for medicine or AI for public health. I feel medical imaging analysis is one of the area in the next few years will have a very broad adoption. Earlier last year, Nature Medicine actually has the entire issue, 8 articles talking about AI for medicine. What's amazing about this is most of the papers have clinical results, validated results of using AI technology for all kinds of diagnosis, treatment, prevention actions. So it's no longer technologists or AI scientists trying to figure out what they can help in the medical domain. It's already in a stage that AI has been everywhere in the hospitals and has been widely used by radiologists, by oncologists, by physicians. And I think this is going to come very big in the next 10 years with broader adoption. And focusing on medical imaging analysis, many of us in this area know computer vision has gone a very long way in the past few years. Many people already quoted that machine today can recognize visual objects with greater accuracy than human eyes, especially for eyes like my age. Machine seems to be much better. Therefore, it's becoming a very valid question to ask: can AI or computer vision machines replace radiologists, replace physicians? Which what we have seen in how computer vision helps selling car to deal with all kinds of situations that the car need to deal with. Seems like replacing radiologists is a piece of cake, but it's not quite. So I want to give you some flavor of why we're not there yet, especially from the angle of why medical imaging data has this very special characteristic which makes it difficult, and how they're very different from the natural image data, which has been have a revolutionary changes in the last 5 years. So first thing is resolution and data amount. There are much fewer data and higher resolution for medical data than the natural image in the wild. So left-hand side, you can see many of us working in computer vision or AI. You heard about ImageNet, you heard about all kinds of data that CFA 800, CFA 100, and MNIST. Then number of images you talk about in a data set is tens of millions of those. And the resolution wise, they're in hundreds by hundreds of that kind of resolution. But if you look at the public data set for medical images, we're talking about 30 patients, 100 patients. I actually recently working with Zhongxin hospitals in Wuhan on COVID-19. Personally, they gave us a patient for the lung CT images. 500 patients, that's enormous amount of data. But each patient, we're talking about gigabytes of data. And each patient, each image is in the order of 1,000 by 1,000 resolution minimally. So just give you an idea that they're very different. Second thing is the medical image data, even though in appearance look like gray color, it's not as rich as natural images, but they're highly complex. The anatomical structure are complex, and there's high correlation among the regions. I'll give example like this automated segmentation of brain in the left-hand side required segmenting the brain into 93 regions. It's not easy. And the right-hand side showed that if you look at the brain images, the white matter, gray matter versus the cerebral and spiral fluid images, they're correlated. That's why it takes years of training for radiologists, for physicians to understand the very complex correlation, which doesn't exist in natural images. So what I'm trying to say is natural images, even though in terms of number of pixels, it's easy. But finally, I would say, due to time limit, is reading these images require very high professional knowledge. The left-hand side, you ask kindergartner, and they can tell you how many horses in the picture. And the right-hand side, I will ask you which one is normal, benign, ligament. It's very difficult. You really can only rely on very few radiologists to read it. And finally is privacy protection. So I got a message from Pascale that I probably should stop here. So final point is there are a lot of AI techniques can address this limited, these challenges for limited annotated data and to preserve privacy. So I list out a few directions, but I'm not going to read this. If you're interested in, I'll find other places to share some more technical directions for AI supporting medical image analysis. Okay, thank you.
Thank you, Tim. Thank you so much. Yeah, so your last point about data privacy is actually very, very important. Maybe we'll ask the other panelists to also talk about this issue afterwards. So thank you, Tim.
Thank you.
Yeah. Well, I know you need to go soon for another meeting, but hopefully we'll have another chance to learn from you on your view about the data privacy, the need for data.
Thank you.
Thank you so much, Tim. So
Thank
now,
you,
Shahnaz, Dr. Miri. So I have so much admiration for you because you are really working in the forefront of this fight against COVID-19. You have been diagnosing patients. You have, and I remember I was introduced to you because you invented a algorithm that can diagnose COVID-19 over a distance by the patient's breathing and the way they talk. And it came about in a very personal way. Can you tell us about your story?
Sure, definitely. Thank you so much for inviting me here, and thank you for the introduction. So as we discussed before, yes, it was a personal story. One of my family members developed some symptoms of fever, and she was just sending me messages via WhatsApp. and sending me voice messages that what she's doing and what are her symptoms. And then after a few days, I was just listening to her voices, and I noticed some changes. The way that she was speaking, it was like more kind of broken speech, speaking like just few words and then taking a deep breath again, continuing the conversation. So I noticed that, and at the end, she was diagnosed with COVID-19, and she was admitted to the hospital. And over the course of hospital admission, I was monitoring her with her voice. I was asking her to actually send me some other like kind of breathing exercise and speech exercises, and I was getting those data and analyzing myself just to monitor her disease progression. And I found all that, like her clinical symptoms in her voice, and then as she was getting treated and she was getting better, those were improving. So then I discussed that with a team and with a team of AI speech scientists, and then now we are developing that application, a combination of tests for diagnosing respiratory distress, which happens in COVID-19 patients.
Yeah, so before we get to your presentation about the details of this program, I also want to mention that I'm very grateful that a dear friend of mine in New York City, when she had symptoms, but she could not be tested. She wanted people to know that she just could not get tested, nor could she get treatment. So I asked for your help to, and then you were so kind that you immediately got on the phone and the video chat with her, and you talked to her, and she was using your program. And you monitor her and help her through the whole thing. And I'm very, very grateful to you. And this is amazing. So I would like to give you some time to introduce your work and this particular program of remote testing via using AI. Actually, it's very interesting. So could you, perhaps you can share your screen, and maybe you can have 5 to 10 minutes to introduce a little bit about the program.
Sure. Thank you.
You should use presentation, yeah.
So this is the application, powered AI virtual auscultation and respiratory function assessment as a biomarker for respiratory involvement in COVID-19. So as we know that, so COVID-19 has a lot of different symptoms, including fever, myalgia, cough, shortness of breath. But the most important part, the most important symptoms is worsening shortness of breath, because otherwise, according to CDC guideline, those people with low risk should stay at home and just continue like conservative management, clinical monitoring. But how do we detect worsening shortness of breath? How people at home can detect that to just take some actions about it? So the problem is right now, the remote monitoring guidelines for COVID-19 patients or those who are exposed is just rely on patient self-reporting of the severity of their shortness of breath. And there is a lot of bias and a lot of confusion. They're not medical experts, so they are people getting confused and getting anxious about like what is going to happen to them. So there is like really no remote monitoring tool for people to get, symptomatically monitored. And the test that is out there, the PCR test, has a 40% false negative rate, and even that is not available for everyone. So what we did is just using audio signal as a measure for evaluating breathing. So as you see here in the photo before, in the bottom, so we have a pulmonary function test which uses the respiratory flow. There is a machine that people will blow inside the machine, and that will measure the volume of their the air they're exhaling. And we are actually getting the similar signal of airflow using just smartphone and using a microphone in a smartphone. So using that, we also combine not only just the airflow But also we are combining that with some functional measures that we don't get that in the spirometry test. And that is a speech assessment, which is very important from functional standpoint. And also deep breathing assessment, we can hear some extra noises like wheezing, like bronchitis, or like extra abnormal breathing sounds, stridors that shouldn't be there. And if there is those like abnormal sounds, then there is a like respiratory distress. Also cough pattern, as well as some other counting tests that we usually use in neurology just to evaluate people with neuromuscular weakness, that they cannot take the air in their lung. So first step is speech assessment. So we developed some standard text, and actually we have translated this so far to 4 different languages, and we are planning to translate this to more other languages to just make it accessible everywhere. So one person will start reading this, and while they're recording their voice, and we will just evaluate their speech. The very basic measure that we can get it, like I as a physician, I can get from this speech is the number of breathing. As you see in the left side, this is a spectrogram of the speech. In the left side, you can see that this is a COVID-19 patient at the time of hospital admission. You see every few words, there is one breathing, total 18 breathing, 18 breathing in 1 minute. And then this is 2 weeks after treatment, and you see it's total 11 breathing in the same amount of duration of time. And as you see, this is the progress that we see here. So on the day of diagnosis, there was 20% breathing in 1 minute of a speech. And then as you see with the treatment, it's getting improved. And this is important from medical standpoint, so because we want to just monitor people and just see who has mild symptoms, who is getting worse, and who needs to get further investigation. And you see here, there is another example. So a person who was at the baseline, this is a year ago, the speech analysis is normal, like about 4% of his breathing. And then like right before the diagnosis is coming up to 8%. This is before PCR testing, and this is the like 2 days after the PCR testing comes back positive. So we can see and this is just a breathing factor. So we have other feature extraction that we are doing to just create models in the speech, because phonetics also will change. So we are working on that right now. And the next one is deep breathing assessment. Again, we ask people to just take a deep breath with open mouth and record. And then here you see, again, this is on the top, COVID-19 patient. At the time of diagnosis, you see high frequency sounds in her breathing, and you see some high extra signals here. It's kind of wheezing sounds in her breathing. And as you see with her improvement after 2 weeks, you see those high frequency sounds in inhalation and exhalation are improved, and this is a normal person. So this is another work that we did with NYU, Dr. Cho, and this is a recording with telephone, with cell phone. And as you see, the frequency, there is a frequency limit because cell phone will record only 4,000 hertz. So it's not as wide range as the other one that we use cell phone. But still in this one, in the breathing, you see this is COVID-19 patients, and this is healthy people. And as you see, there is a high area under care of 80% in some specific signal some specific frequency of the breathing, you can detect the difference. So these patients, they have more high frequency breathing. And you see here, this is wheezing that we can hear, and these are the stridors that we can see the spectrum of the speech in patients. Next test is a counting test. And in counting test, we routinely use this in neurology for myasthenia gravis patients, those who have neuromuscular weakness, and they come with the exacerbation of the disease to the hospital. So we should closely monitor because they crash so rapidly. And we ask them to just use this counting test to just see how far they can count with one single breath. And we see that difference in some person who has pneumonia or some other reason for lung involvement. And here we can see a normal control compared to a patient has a shorter duration. But what is that like in different category, age category, or you know, different height, and like other medical condition can affect that. So we are collecting more data to standardize that. But other than that, one person can be a control for herself or himself. So over time, if someone has a baseline, over time they can compare themselves, their test result. And we are making that automation to just detect the first breath and then counting, and then second breath after that to just measure that duration of the counting test. And here there is another test, a Gaffani test that we use for detection of pneumonia when we use digital stethoscope. Here you can see the bottom ones are digital stethoscope. When we ask the patient to say E and A, so we'll take a look at the difference between E and A. In a normal person, you will see the difference in the letter E and in the spectrum that you get. But in a pneumonia patient, you don't see much difference. And here, the top one is the voice. So we'll ask them to just say E and I again, just as a voice recording. And here we see that still there is a difference between normal person and COVID-19 patient. There is more breathy E and I, and they go out of breath just shortly compared to a normal control. So that is still exploratory, and we're working on that to just create models. And then last thing is cough test. So we know that cough is another like common symptoms in COVID-19, and we are just getting those cough data to create models. So this is a COVID-19 patient, you ask them to intentionally cough, and they cannot stop until they go out of breath. But you see a normal person has a strong cough, 3 coughs, and then take a deep breath, and again another cough. And we see some other like abnormal, these are also COVID-19 coughs. So we'll see some other abnormal wheezing in their cough that can just help us give us more information about their underlying diagnosis, like COPD or other like pulmonary conditions. And here we are in the same application, we are collecting some demographics, some age, height, BM, and weight, as well as some other relative underlying diseases like heart disease, lung disease, to just get the more information to just combine with the data we get. And then as you see, we are just collecting that by a laptop, tablet, or cell phone. And we just record that data to the cloud, and we create models to just give the result immediately back to the users. And the reporting will have different sections. Again, we are trying to just get the basic output data in the first step, but we are going to try to create models just to visualize it simply so that everyone can use that. And the final application of that, this application can be just for healthy people, as I have so many other physicians friends who I asked them to just take this because they have a lot of COVID-19 exposure. And actually just recently I diagnosed one of them because she developed some symptoms, and I compared her the data before, like 2 weeks before that she was healthy and after. And that helped a lot because we took action quickly, and she just got the medical attention, and she improved shortly, a few days after that, just because it was diagnosed early. And also those who are in, as I said, exposed to COVID-19, if they want to make sure they're detecting any symptoms, or for those who are having mild symptoms, they are staying at home. Or in clinical trials, this is important right now, they're trying different vaccines and medications, so it's important to have a value, a measure, a digital measurement to just prove that improvement with a medication or like other type of interventions. And in telemedicine, before visits, when patients are waiting to connect to their doctor, so they can just use it to just give like some initial information to their physicians in ER for triaging people. And even in the hospital, if the healthcare system is like too busy and overwhelmed, they can use such application in the future. And this is our team, and thank you for listening to this, and I will be happy to answer any questions.
Thank you, Shahnaz. So let's go to the panel sort of roundtable now. You can stop sharing. All right, thank you. So, so I have some questions. The audience are also welcome to send questions through the chat, and then we can, the panelists can answer your questions there as well. So I'll start by asking the panelists. Tim had to go to another meeting, so we have 3 panelists now. I would like to ask you the question, because you already actually touched upon that before. And, you know, and so I guess the first question I would like to ask is, what are the challenges of using AI in the public health? Is it data privacy issue, computing resources, others? What about regulations or governance? What are your views? So let me know who wants to answer first, and or should I do a round robin kind of thing?
I'm happy to start, Pascale. I'll be brave and go first, shall I?
Okay, please.
I think, you know, I think there are, you know, there's certainly a number of challenges when it comes to maybe making that, you know, I referred to, you know, the importance of connecting our insights that we gain through either through, you know, AI, or, you know, using big data, or let's say some type of mining approach of big data, and verifying that as something real. And whether it's public health or it's in a clinical event, you know, there does need to be that connection. So I think framing the use of AI in a way that remains grounded in what we're doing, whether it's providing clinical care to patients or whether it's providing public health services to a community, you know, that has to be quite clearly our endpoint. And then we work back and use the new tools and the new data that we have available, which I think were wonderfully illustrated by Shahnaz, you know, how we can use those. But at the end of that process, there still needs to be some human interaction there. So I think that then we need to give a clear message, especially as we go forwards, when I think the world will be investing significantly in all sorts of technologies going around the world, that this is not going to be a replacement for doctors and nurses on the front line. It's not going to be a replacement for public health workers and community level workers, but these are tools to help us do our jobs better. So I think there's a framing challenge for us, and it's really important that we get that right. There are all sorts of other challenges, but I think that's one that at least I'm grappling with in my mind, is getting that balance right.
Well, thank you. Shahnaz, Amandeep, what is your view on the data privacy regulation? And, you know, people are also afraid of AI. I mean, you already addressed this a bit, which is that, can AI take over humans? Obviously not. In Shahnaz's case, you know, you still need the doctor at the end of the chain to look at the detection performed by AI and to make the decisions of treatment and so on. So what are your views, Amandeep and Shahnaz, on this question?
I think there are a number of challenges, but if I were to single out a few that are the most important, in addition to what Oliver said, which is the human interface, the context around AI use has to be framed properly. I would list number one, the absence of meaningful data sets. So there is a poverty of data, there's a paucity of meaningful data. And if data is out there, it's not accessible, it's not interoperable. Take the French health data hub. So they had the supply chain data, which was sitting there, and till the team in the French health data hub worked on it and flattened out that data hierarchy and started to extract some insights, let's say about drug reactions, this data was not available for public health, for precision public health. Then the second challenge is the governance challenge, and this encompasses the privacy issue, data protection, data privacy, incentives around data use, also fair use of data, so that there is a value extraction is not just limited to a few players. The third issue that I would like to highlight is that this is not democratic enough. AI capacity, AI knowledge is not spread evenly across the world. We know this, it's concentrated in a few geographies. So we need to up the inclusive aspect of AI use if we are to really make an impact at a large scale. I see a lot of boutique approaches. They are wonderful approaches, but we need a bigger canvas to bring them together and get scale, get recognition from funders, from public authorities. And I'm sometimes concerned that if we try in a very competitive boutique type of a way, then policymakers will get switched out. They say, this is another fad, and let me just invest in what has worked in the past. So we need to make the case in a good way.
From my standpoint, in the US, so we have some restrict HIPAA rule. So we should be very careful about just handling any kind of data with identifiable information. So right now, our application does not collect any identifiable information because right now we're in the research phase. But the problem is this needs to be delivered to those patients, physicians, or healthcare providers, because at some point, if they want to just create an alert to them, there should be some communication. So we are planning to implement that in the, for example, telehealth platform when they start a video call, like right before that, they can use that. And we have this discussion about, do we at all need to collect the information, or we just need just connect person to a specific certain code to just add that to their medical record. So that's most likely our approach. But we definitely, I think personally, right now we don't have that plan, but I think if that data doesn't go to patient's medical record, it's kind of useless because no one will know about what's going on. And it is difficult if there is no name on that data. No physician will take the responsibility to put that in the medical record, just because there is legal issue. So it's a difficult time, but I think there are ways to just use this and connect this to patient's record.
Thank you so much. My next question has to do, actually, I think all of you already touched upon this, which is the need for international collaboration, not just for AI, but big data, but it's for AI and big data for public health. So not just for COVID-19, but for public health in general. So we have seen, it's very interesting to me to observe that today in the world, we see a lot of antagonism, a lot of blaming between nations at the political level. But in fact, from the very beginning, we have seen a lot of publications and a lot of collaboration from scientists, right, on fighting this pandemic. In fact, our tool, the team introduced earlier, is a natural language neuro question answering and summarization tool that allows experts to ask questions and finances from You know, today is 57,000 publications on COVID-19 coronavirus, and it's growing by the day. So, so there's a lot of collaboration at the scientific level, but the public doesn't seem to know about it. And like the public seems like to the public there seems to be like the perception that there's like almost like an arms race in this, which is not the case at all. So, what are your views on the need for international collaboration in AI for public health? And you know, Oliver, Amandeep, you have seen this. And Shahnaz, you're in the middle of it. And obviously we're collaborating. We're not even, we actually have never met physically, right? We've been working in this. So what are your views on how, you know, how can we not only, you know, the need for international collaboration in fighting COVID-19, but is there any way we can, you know, have this, carry this message to the public and for the public to see that this is a collaborative effort and, you know, world peace and all. What are your views on this?
Yeah, and if I may, you know, this is not the first time we're seeing such rivalry over technologies, over a specific domain. We've had the nuclear arms race, the space race, and currently, unfortunately, the climate is not good for collaborations around technology. But I think the more we stay with science-based, global public goods type of approaches, the more exemplars we create for good international collaboration. So one good example today is the collaborations around sharing of genome sequences. So those stories need to be highlighted, and we need to build new models of international collaboration. Frankly, the 20th century models are no longer so practical. And in the digital domain, they need to be reinvented. That's the raison d'etre of what we are trying to do in I-DAIR. But we need to multiply these efforts. The scientists and the technologists need to make the case themselves. They shouldn't wait for international organizations, national governments to do that. They should themselves start organizing these collaborations that show results, and that then reduces this friction, this competitive beggar thy neighbor type of an approach.
Well, spoken like a real diplomat and, you know, a world affair expert. So I just wonder, you know, what we can do more. So Oliver, what's your view on this? Like, how can scientists to technologists, you know, people working out, what can we do more in, you know, in improving international collaboration at all levels, especially in public health area and in the current pandemic crisis?
Well, I mean, as you alluded to, there's certainly some great examples of international collaboration, and it's clearly not a all negative or all positive story out there. There are, and as Amandeep mentioned, you know, sharing of genomic sequencing data for COVID and for many other diseases, it's a really kind of pathfinder example of where public good sharing is really now the norm. We're not there yet with public health data, and I think there are a number of structural challenges that still have to be overcome. I think it, you know, I think at the moment maybe the benefits of sharing large amounts of data are maybe a little bit unclear for data owners, because some of the data technology applications are really around the data mining or a data mining type approach by which we effectively say, give us your data, we'll look through it and see if there's something interesting in it. Whereas maybe being a little bit more specific about what we require from data would help us start that journey a bit better. I think in the genome sequencing world, I think there's a more direct connection between what happens when somebody shares a sequence and what the benefit of that is. You can see that quite directly. But if we simply ask entities to share all of the data that they have with the hope that there might be some benefits from that. I think it's not a clear enough framework. So again, I think we've got a little bit of work to do, certainly in the public health domain, to really articulate what are the benefits here, and you know, whether there are direct benefits or indirect benefits or kind of collective benefits, and I think that piece is still missing a little bit.
Well, thank you. So my next question, I'll combine the next two actually, which is that, you know, today there are a lot of, everybody is talking about the need to identify the origin of the virus. And then the other thing that's very much urgent in everybody's view is how to find a vaccine. And then, so I would like to hear your view on how AI can help in these two tasks. And also how AI can help in preventing future pandemics, such as COVID-19. What are your views on this? Or we can start, you can answer the first part of the question, which is how we can help with the, those two pressing issues in COVID-19. Who wants to go first?
Maybe I'll take the political question.
Okay.
Again, there are existing references for such work. If you look at the Biological and Toxin Weapons Convention, and I chaired the meetings in 2017, there is a template for the international community to collaborate, investigate something. Was it deliberate or accidental? But those mechanisms again are 20th century mechanisms, and there's not enough trust in them. So we need to rework those mechanisms so that there is no finger pointing, that there is an incentive to share information. People are not scared of sharing information, and that this is done in a fair manner. It doesn't become a political football. So I think there is some work required, and technology can certainly help. If, like in some parts of international organizations, the secretariat has a strong scientific basis. I'm thinking of the International Atomic Energy Agency, for example. So it brings an objective ground truth to the policy discussion. So if AI could contribute to building over a period of time, this can't happen overnight, through an array of sensors, through a network, international network that everyone is invested in, brings some scientific information on a regular basis, then that provides the basis, the foundation for working those mechanisms. But this will take a lot of hard work, and it might even take a decade or so, but I think it's worthwhile investing in such an effort.
Well, thank you so much.
Well, maybe to Pascale, to your question about, you know, what are some of the you know, the applications, you know, direct applications now that we need to focus our AI capacities on, or our data science capacities on. I think we're entering into, let's say, you know, the second chapter maybe of this pandemic. So if we said the first chapter was the initial spread around the world and the occurrence of large outbreaks, and now, and with this, the implementation of very tough control measures around the world, the question now that we're all facing is, how do we manage that risk going forwards? And what we collectively and what governments need to do is balance this question that in at least 3 dimensions, probably more. So somehow we need to figure out how to balance the public health risks, the economic impacts of the economic risks, and the social impacts as well. And there are some other dimensions, but just to keep the argument fairly, you know, simple, we now need to balance these 3 things in a very dynamic way, in a kind of risk management approach, so that we can move forward as a kind of global community without maybe one of those 3 domains let's say, displacing the other two. But we don't really know how to do that, and it's a very, very complex process. One could imagine setting up a data center to try and look at indicators of those three dimensions and see how they relate to each other. And that differs a lot in different countries, different contexts, and we can't do it for, you know, it can't be the same. The relationship between those three is not actually the same around the world. It depends very much by country, and even within countries, by communities, really. But how can we harness the data that we do have? We do have a lot of data, of course, on each of those three domains. How can we harness those data to understand that dynamic equilibrium between those three domains, which are constantly in balance, and feed that into a better risk management approach going forwards? So that would be a kind of a big picture idea about how we could use AI for tackling a problem that's really complex for us to manage in a kind of a more two-dimensional way.
Okay. Thank you. Shahnaz, you want to comment on the current application while you are in the midst of it, and what we could, so yeah, I will come back to all three of you with which is what can we do to prevent another pandemic crisis? Like that's, anybody wants to comment? Like, what can we do now for tomorrow, in a way, other than governance? Of course, you already mentioned, but what can AI do? What can we use AI? Are AI researchers doing enough? Are we doing enough? What should we be thinking about today? Shahnaz, what do you want us to think about? What should we work on today or tomorrow?
So I think just having more tools, like easy, simple tools to measure symptoms and to track people, to monitor people. That's definitely things that we want, because right now, even right now in our, sorry, my throat is dry. So even right now in our medical settings, so many things are subjective, and I would rather have things like objective and measured, and AI definitely is a great tool. And I myself, I'm looking over like all the, like anything that I can collect more data and just document the data. So we need more AI tools. That's about it.
For diagnosis and for assisting doctors, I imagine AI tools. Also for assisting researchers, perhaps in you know, to do more research.
Definitely. So, for example, right now in most of the current ongoing clinical trials, the endpoint measures are mainly like the day of hospital admission, the ICU admission, or some measures of like respiratory rate or vitals, or some other numbers for sure, some other imaging. But again, that can be just more accurate to like using AI. We can just develop more tools to just use in this clinical research, clinical trial. Move on faster.
If I may quickly jump in here, I think that's a great point. We need more cross-domain expertise. So we need more doctors with AI and data science expertise, and we need more AI specialists with knowledge of the public health domain, complex domain, as Oliver underlined.
Okay, that's very important. Cross-domain knowledge. So AI today really has you know, wide ranging impact, and in public health, we also need to have people who are both trained in AI and perhaps medical domain. You know, so to work with someone like Shahnaz, it would be good that we also are more aware of the problems there. You know, Shahnaz, you're not just a user, and Amandeep as well, Oliver, you're not just users, you're actually active participants in creating the AI technology. So we can no longer just sit in our labs and dreaming up of algorithms and then like look around, oh, what can we apply it to? We are actually, AI researchers have to really look at the pressing needs in public health. And this has been highlighted in the current crisis. So, so we are pretty much, yeah, we're pretty much at the end of the panel discussion. I would like to give each one of you an opportunity to say the last words that you want to say on this topic. Anything you want to say to conclude today's panel discussion, and maybe we take a couple questions from the audience. Any last words?
Well, Pascale, maybe just to touch on the last kind of discussion point about, you know, looking forward and what could be different the next time around. I think, right. You know, I think there is a lot of work, as Amandeep mentioned. There's a lot of work to do to get the global data architecture and infrastructure and environment more conducive to applying contemporary data science approaches to public health. I think we, to illustrate, at W.H.O last year, we started an initiative called EpiBrain, and I've sent you the link for that, yes. Which you can share with everybody participating. And this initiative really recognizes the need to build this new global data architecture for public health. Kind of a foundational aspect of that is that we need to build what we call within the EpiBrain initiative the semantic web, which is the ontologies and taxonomies that are needed for us to really leverage data within the public health domain. And that's actually quite a significant foundational piece of work that we need to do to set us going forwards for global collaborations. There's some other elements that we need to leverage, which we don't currently have within the public health capacities, such as larger scale computing power. We're actually collaborating with CERN on that as a kind of close geographic neighbor to help us make that first step. But public health hasn't invested on the most part in adequate computing power or infrastructure. And we do need to look at that as we go forwards. And then I think there are a number of applications or uses that we are already trying to explore. I mentioned at the beginning our work that you and I have together on EIOS, which is detecting signals of potential events within, let's say, the large noise of data that's out there. But there are other aspects that we're already working on, and we have a very significant supply chain initiative, and I was very interested to hear Amandeep mention the similar problem that he's encountered around supply chain, which is both anticipating what would be needed, but also figuring out the most efficient way of addressing some supply chain issues, especially during public health crises. And there are other applications such as scenario planning and simulations, which with a greater set of data, our scenario planning and simulations could be much more impactful. And while we have many tabletop exercises and scenarios that are done currently, the level of sophistication, I think, could be increased quite significantly. So moving forwards, I think we do need a big vision for public health. I think we need a global collaboration around large data for public health and AI for public health. And I think we're already seeing some initial steps along that journey. And I hope that in the near future, actually, that we'll be seeing some of the results of that.
Thank you so much, Oliver. So any concluding remarks from Shahnaz, Amandeep? A message for us all? I do see there's a question from the audience, but I would like to give you a chance to make a...
Yeah, no, I read that question. It's it's a very difficult question to answer. How can AI help individuals, societies in responding to pandemics? I think we need to try a lot of things. And most importantly, my big message today is we need to bring young researchers across domains into this problem solving and develop a new generation of international collaborators. Problems, who knows the answers to these problems may come from a young researcher in Africa, in Southern Asia, in Southeast Asia, who knows? So we need to make it easier and intuitive for such people to participate in the problem solving rather than the old ways of top-down problem solving. You know, someone sitting in a big campus, big international organization has the answers, etc. So that's my message.
Thank you so much. Thank you, Shahnaz.
To answer to that question, or
the last or just a final remark.
Okay.
Message for our students or our faculty.
Sure. Thank you so much for this opportunity, and I think this was a great experience for me as myself as a physician who can access to AI scientists to just translate what they see, because we see a lot after like years of training in medical in medical school, in residency, in fellowship training, but just translation of what we see is not out there yet. And as Amandeep was mentioning in his speech, and also like we don't have access really much to AI scientists, and we really are happy to have that help, because there are so many things that we do without, that doesn't really need that much effort to do, and we can just make all those automation. But again, I think there should be more collaboration in the future.
Thank you. So we are actually over time, so I will just take one question from the audience, and this looks like from one of our students. What do you think AI can be used to prevent the pandemic from happening in our daily life for the future? So what can we use it in daily lives to prevent a future pandemic? So any takers of the question?
Yeah, I think we maybe I'll just have a quick go at that, and my colleagues can join.
Sure.
Maybe if I come back to my earlier comments, which is that the fundamentals of public health remain the same, and that's empowerment of individuals and communities, awareness and understanding, throughout all levels of societies. Adequate investments at the government level in public health systems, and an array of things, and I think AI can really help us understand some features of public health which we know are important but maybe don't have full understanding of. So just one example off the top of my head, which would be, for example, the how people mix socially. Is an area of a lot of interest, and people's behavior, which is also obviously driven by people's understanding and beliefs, is the main driver of at least infectious disease outbreaks, whether they're pandemic or local. It doesn't matter. There's a very important cultural aspect in every single infectious disease outbreak, but getting a better understanding of how of how that relates to disease transmission would be enormously helpful, and that those types of applications, which we already see happening now, are accelerating, and I think will really provide a lot of insights into how diseases spread in our contemporary world.
Thank you so much. We have come to the end of today's webinar on AI and public health. I would like to thank our distinguished panelists. So Ambassador Amandeep Singh of I-DAIR, and Dr. Shahnaz Miri from Georgetown University Hospital, and Dr. Oliver Morgan from the WHO. So thank you so much for today's wonderful discussions and presentations from all of you.